Welcome to the deep dive. Today we're tackling a really significant issue, preventing youth violence. You sent over some compelling research on this, and we're going to pull out the key insights for you.
Exactly. You've tasked us with understanding how school health instruction can be, well, a tool in addressing this complex problem.
And our main lens for this deep dive is a fascinating 1995 article from the Educational Psychology Review titled The Role of School Health Instruction in Preventing Interpersonal Violence. It's all about how schools can step up in violence prevention through health education.
Right. And for you, our listener, who's keen on getting a solid understanding without getting bogged down, this article provides a really structured way to look at how school-based efforts can help, what their potential is, and also what hurdles they face. We're aiming for those aha moments, really.
Okay, let's unpack this. The article starts by laying out just how big of a deal youth violence is. They call it a staggering problem, not just socially and humanly, but also from a public health and even moral standpoint. It's described as having deep social roots.
What's fascinating here is their immediate emphasis on a multifaceted approach. They're not saying education is the silver bullet. They stress that it needs to work alongside, legal changes and modifications to the environment.
Right, it's a combination of efforts.
Beyond the classroom, the article underscores a crucial point. Education's power in curbing youth violence is amplified when coupled with tangible shifts in legal frameworks and the broader environment. This highlights the interconnectedness of societal factors in tackling this issue.
Right, it's definitely a combination. Now, they do bring up an interesting point about the effectiveness of school health instruction in actually reducing risky behaviors.
Mm.
They say it's uncertain.
That's a crucial bit of nuance, yeah. However, they quickly follow that up with a more optimistic note, pointing out that well-designed programs aimed at at-risk youth do show promise. They even draw parallels to past public health successes.
Like what kind of successes?
Think about things like anti-smoking campaigns. Those often involved education as a key component.
It's interesting how they draw parallels to anti-smoking campaigns. Were there specific elements of those campaigns that the article suggests could be relevant to violence prevention?
Well, they don't go into super granular detail, but the underlying principle is similar. Sustained, well-designed educational efforts can shift attitudes and behaviors over time, especially when combined with broader societal changes. The long-term nature of those anti-smoking initiatives, that's kind of a key takeaway.
That makes sense. And here's where it gets really interesting. The article mentions that when youth violence really hit the national radar, there was this huge demand for immediate action.
Right, and as often happens in such situations, the urgency to do something sometimes overshadowed the more careful steps of evaluating and designing those programs properly. It's a common challenge in public health responses.
Yeah, that feels like a pattern we still see today in various social issues, doesn't it?
It does. They point out that lots of programs popped up, helping many kids, but without much solid proof that they were actually effective in the long run.
This reminds me of how sometimes we jump to solutions before fully understanding the problem.
It does, and they make a clear distinction, noting that while immediate medical treatment is different, prevention programs really need that strong foundation of evaluation to show what works and what doesn't. But they do mention that some programs were showing positive signs even back then.
Okay, so the problem is huge and complex. And while school health can play a role, it needs to be part of a bigger picture and carefully thought out. Now, the article then dives into what they call comprehensive school health programs, or CSHP.
All right, CSHP.
CSHP sounds like a broad concept. What are some of the key distinctions between it and traditional health education programs?
Think of CSHP as the overarching framework. It's not just about what happens in the classroom. It's described as a whole system of policies, procedures, and activities within a school that are all aimed at looking after the health and well-being of both students and staff.
Interesting. Staff, too.
Yeah. The vision of CSHP presented here is remarkably forward-thinking, positioning the school not just as a place of learning, but as a central hub for holistic well-being. The inclusion of everything from food services to psychological support underscores the understanding that, a child's capacity for positive behavior is deeply intertwined with their overall health.
So it's more than just health class.
Absolutely. The article emphasizes that it should include things like health services, making sure the school environment itself is healthy, and then, crucially, school health education. But it doesn't stop there.
Okay.
They list guidance and counseling, physical education, food services, social work, psychological services, and even employee health promotion as part of this comprehensive approach. It's really about embedding health into the entire fabric of the school.
That sounds really holistic. And within that, we have school health education, or SHE. How does that fit in?
SHE is the classroom instruction piece of that bigger CSHP puzzle. It's the deliberate effort to influence students' knowledge, attitudes, and behaviors related to health through a planned curriculum from kindergarten all the way through 12th grade.
K through 12.
Yeah. This involves setting specific goals and objectives, deciding what content to teach and in what order, and creating actual lesson plans.
And traditionally, what kind of topics would a school health curriculum cover?
The article lays out a pretty standard list: community and environmental health, consumer health, family life, human sexuality, growth and development, mental and emotional health, personal hygiene, fitness, nutrition, injury prevention and safety, diseases and disorders, and substance use and abuse. So a pretty broad range of health-related topics.
It sounds like if a school district has a strong CSHP in place, they'd be in a much better position to effectively teach about preventing violence.
That's precisely the argument. The authors suggest that these strong, integrated programs provide the necessary foundation. However, they also point out a significant barrier. Back in 1995, these model CSHPs were the exception rather than the rule in the U.S.
That definitely throws a wrench in the works. So what was the actual state of violence prevention instruction in schools at that time?
Well, the article notes that while most states did address school health education in some way, fewer actually mandated it. And surprisingly, even among the states that required specific health topics, none of them specifically mandated education on preventing interpersonal violence.
Wow, that's eye-opening. So even though it was recognized as a big problem, it wasn't necessarily a required part of health education in most places.
Exactly. However, it wasn't all doom and gloom. They mentioned that over half of school districts reported having some kind of violence prevention efforts underway. But then, a national survey from 1989 found that less than half of 8th and 10th graders said they'd actually received instruction on it.
So there was a disconnect between efforts at the district level and what students were experiencing.
Definitely a disconnect.
And the amount of time spent on health instruction in general seems to be a factor, right? They bring up that school health education evaluation study.
Yes, that study suggested that you really need at least 50 hours of quality health education to see positive changes in students' health knowledge, attitudes, and behaviors. But in 1989, only a minority of states had specific time requirements, and the average annual hours varied quite a bit depending on the grade level, often falling short of that 50-hour mark.
Falling short.
Yeah. Plus, a significant number of students were getting hardly any health instruction at all. This really underscores the challenge of prioritizing health education within packed school schedules.
So even if violence prevention was being touched on, it might not have been getting the dedicated time needed to really make an impact. And what about the teachers? Who was teaching this stuff and what were their qualifications?
That's another critical piece of the puzzle. The article points out that state certification requirements for health educators varied quite a bit. In many states, you could get certified in health, but it wasn't legally required to teach it.
Oh, really?
Yeah. And at the elementary level, it was even less standardized, with very few states requiring health-specific certification. While some states required elementary teachers to take a health education course, far fewer required them to have in-depth knowledge in personal health and teaching methods.
Wow.
At the secondary level, more states required health certification, but the number of required hours still varied considerably. This inconsistency in teacher preparation likely impacted the quality and effectiveness of health instruction, including, violence prevention.
It sounds like the consistency and expertise of health educators were potential weaknesses in the system. Okay, so if a school did want to implement violence prevention education, what kind of goals and content should they be focusing on?
The authors emphasize that instruction should be driven by the learner's needs and the specific objectives of the program. Clear instructional objectives help define what content will be covered and what kind of behaviors the program aims to encourage. They also stress the importance of having a strong conceptual framework and a theoretical basis for how the information will be used and where it comes from.
And what kind of actual topics should be included in the curriculum itself?
Well, the content needs to be age-appropriate and reflect the student's developmental stage, their existing health problems based on data, their needs and interests, and also the health issues within their community. They also highlight the importance of cultural diversity in both the content and the teaching methods used.
Cultural diversity, right?
And the Coalition of National Health Organizations recommended that the final decisions about content should be made at the local school district level, but encouraged guidance from state education and public health departments. This local focus recognizes that the specific manifestations and drivers of youth violence can vary significantly from one community to another.
That local control makes sense, given the different needs of communities. But what are some of the key areas that should generally be covered?
The article suggests several key areas. Understanding the risk factors associated with violence, including social attitudes that condone it, developing crucial social and life skills, encouraging pro-social behaviors, and explicitly not condoning antisocial behavior.
Not condoning it. Okay.
They also emphasize including instruction on preventing both intentional and unintentional injuries and on personal safety precautions. Ultimately, the content should align with a clear instructional philosophy that has the support of the community. It's about more than just information. It's about shaping values and building skills.
So it's not just about saying violence is bad, but actually digging into the root causes, teaching alternatives, and fostering positive behaviors. Now, how can schools actually deliver this violence prevention education? The article talks about different instructional plans.
Yes, they outline three main approaches. The first is direct teaching, which involves implementing a separate, dedicated violence prevention curriculum, either at specific grade levels or across K-12. This could mean developing a new curriculum or adopting an existing one.
What are the pros and cons of that approach?
Well, a major advantage is the potential to really delve into the topic and potentially change students' knowledge, attitudes, and behaviors. It can be particularly useful for reaching at-risk youth. However, it takes a significant amount of time to develop or adopt and implement such a curriculum, and it could potentially take time away from other important subjects, including general health education.
Right. Time is always an issue.
Despite that, the direct approach often gets political attention, which can be both a pro and a con. The article lists several examples of existing curricula from that time, like Stopping Violence and Second Step.
Okay, so a dedicated curriculum. What's the second method?
The second is integration, which is about weaving violence prevention concepts into existing health units, or even across other core subjects like science, math, or social studies.
Ah, interdisciplinary.
Exactly. For instance, you could discuss conflict resolution skills in a mental health unit, or analyze media portrayals of violence in a language arts class. They even provide an example of an interdisciplinary planning wheel, showing how different subjects could explore the connections between alcohol, drugs, and violence. This approach can highlight the interconnectedness of these issues and show students that violence isn't an isolated problem.
That sounds like a way to reinforce the message across different contexts. But are there any downsides?
Careful planning is absolutely crucial for integration to work effectively. You need to make sure teachers are equipped to handle it, that students can grasp the connections, and that there's a logical flow and no major gaps or unnecessary repetition. The authors caution that if you rely solely on integration, it can lead to a lack of clear responsibility for teaching these concepts and might not be as effective as a more direct approach. As they quote, "Everybody's business to teach health often becomes no one's business."
Ooh, yeah.
The same could be said for violence prevention.
That's a really important point about diluted responsibility. And what's the third approach they mentioned?
The third is supplantation. This is kind of a hybrid approach where you replace an existing unit within a comprehensive health curriculum with a specific violence prevention unit.
Okay, like swapping one out.
Exactly. For example, a school might decide to replace their unit on general injury prevention with a more focused unit on violence and health. A strength of this is that it uses health teachers who already have expertise in health-related topics and teaching methods.
So regardless of the method, direct, integration, supplantation, it sounds like there are some non-negotiables for success.
Absolutely. Detailed planning, extensive teacher training, dedicating sufficient time and resources, and having strong administrative support are essential for any of these approaches to be effective.
Support is key.
Yeah. The authors lean towards the idea that violence instruction is best placed within the larger context of a comprehensive school health program, rather than being a completely separate K-12 curriculum on its own. This reinforces the idea that addressing violence is part of promoting overall health and well-being.
That makes sense. It reinforces the idea that violence prevention is connected to overall health and well-being. Now, the article also delves into the conceptual approaches to violence prevention education. This sounds like the underlying theories that inform these programs.
Exactly. They stress that just giving students information isn't usually enough to change behavior. You need to consider the theoretical basis of your prevention programs. They highlight three key areas. The first is developmentally based education.
What's the core idea there?
The idea is that your curriculum should align with how children of different ages actually understand violence. Younger children tend to focus on the external, visible aspects and think in very black and white terms.
Right.
Intermediate-age kids start to grasp cause and effect and the roles of other people. Older children can understand more complex relationships, multiple causes, and even preventive concepts. So what and how you teach should be tailored to these different developmental stages.
That's a really intuitive idea. You wouldn't explain something like conflict resolution the same way to a kindergartner as you would to a high school student. What's the second theoretical area?
The second is teaching learning theory in general. This looks at factors that influence how students learn. They mention a model that includes things like the student's abilities, their developmental stage, their motivation and self-concept, the amount of instructional time, and importantly, the quality of the teaching.
What kind of the teaching, yeah.
They also emphasize the important roles of the home environment, social influences in the classroom and peer groups, and the impact of media like television. Schools don't exist in isolation, and neither does the issue of violence. This reminds us that a child's learning and behavior are shaped by a multitude of factors.
So it's about creating a supportive learning environment that considers all these different influences. And the third conceptual approach is social skills training. This sounds really practical.
It is. This approach is heavily influenced by the idea of self-efficacy, which, simply put, is a person's belief in their ability to succeed in specific situations or accomplish a task.
Self-efficacy, okay.
The theory suggests that to reduce violence risk, students need not only to know why to change, but also to have the skills and the confidence to do so. Effective programs here would include providing information, developing specific social and self-regulation skills, giving opportunities for practice and feedback to build that self-efficacy, and enlisting social support from parents and the community.
And what kind of specific social skills are we talking about?
The article lists several key skills: self-control, nonviolent conflict resolution, communication skills, resisting peer pressure, assertiveness, and forming positive relationships.
The whole toolkit.
Exactly. They also draw parallels to successful strategies used in preventing other health risk behaviors, like smoking or risky sexual behavior, such as teaching students to recognize risky situations, delay harmful behaviors, and resist negative influences. It's about equipping them with concrete strategies to navigate difficult social situations.
That sounds like equipping kids with a toolkit of positive behaviors to navigate challenging situations. And there's one more theoretical area they touch on: group influence theory.
Yes, this looks at how social dynamics can impact behavior. Diffusion theory suggests that you can influence a larger group by targeting opinion leaders within that group to promote positive change.
Interesting. Target the leaders.
And normative group influence highlights how group norms affect individual behavior. If the prevailing norms support violence prevention, it's more likely to be effective. Educators need to be aware of these social networks and group norms when they're trying to teach violence prevention.
So the peer group matters a lot.
Hugely. If the message goes against the grain of the dominant social group, it might face resistance. Understanding these dynamics can help educators tailor their approaches to be more impactful.
That's really insightful. Understanding the social landscape within a school is key to making these programs work. Now, if a school wants to choose a violence prevention curriculum or materials, what kind of criteria should they be using?
The article says the criteria are pretty similar to what you'd use for selecting any good educational materials. They recommend forming a committee of various stakeholders, teachers, parents, maybe students, administrators, to review potential options.
A committee approach?
Yeah. They even include a modified version of criteria from the U.S. Department of Education for drug prevention curricula, which can be adapted for violence prevention.
What are some of the key things that committee should be looking for?
Things like whether the curriculum has been field tested and what the results were, if it provides current, accurate, and meaningful information, if it's comprehensive across grade levels, if the objectives are clear, if it can be easily integrated into the existing school system, if it's appealing to students.
Student appeal, that's important.
Definitely. Also, if it helps develop important life skills like decision-making, coping, communication, and conflict resolution, if it aligns with school policies, if it can be easily updated, and if there's a teacher training component and an evaluation plan.
Training and evaluation, okay.
They also emphasize the importance of getting input from students, teachers, and parents, including a parent education component, and considering cultural sensitivity. It's a comprehensive list to ensure the chosen materials are effective and appropriate for the school community.
It sounds like a really thorough vetting process is necessary. And they also mentioned the importance of pilot testing.
Absolutely. They strongly recommend pilot testing any curriculum before implementing it school-wide. They mention tools for evaluation and different approaches to pilot testing that can help determine if the materials are effective and suitable for the school's specific needs.
Test it out first.
Exactly. This step allows for adjustments and ensures that resources aren't wasted on ineffective programs.
So careful selection and testing are crucial to avoid implementing programs that might not be effective. Now, even with the best intentions and well-designed programs, the article also discusses the limitations and barriers to violence prevention instruction. What are some of the big challenges?
Well, first off, it's important to have realistic expectations. Classroom health instruction alone isn't going to solve the deeply rooted societal problem of violence. It just can't.
Right, it's not a magic wand.
Not at all. Time constraints are a big factor. Schools often only have a limited number of instructional days to dedicate to this. And the influence of media portraying violence is also a powerful counterforce.
Right, you can teach nonviolence in the classroom, but then kids go home and see something completely different on TV, or nowadays online.
Exactly. The article highlights that effective programs likely need to involve parents, peers, teachers, and the wider community, be adapted to cultural norms, start early in a child's education, and be based on solid theoretical models.
Needs that community buy-in.
Totally. They also stress the need for broader community-wide initiatives that address prevention at primary, secondary, and tertiary levels. School-based instruction is just one piece of a much larger puzzle.
And what were some of the specific barriers that were identified in evaluations of existing programs back then?
A 1991 evaluation found several major hurdles, including securing adequate funding, always an issue, working effectively with often overburdened school systems, gaining community support for gang prevention efforts, and actually conducting thorough evaluations.
Evaluation is tough.
It is. And teacher resistance to new curriculum mandates due to their already heavy workloads was a significant issue. This highlights the practical challenges of implementing new programs within existing school structures.
That makes total sense. Teachers are often asked to do so much. What other barriers did the article point out?
They listed several, including schools implementing ineffective quick-fix solutions driven by emotional responses to incidents, a lack of instructional leadership and support for health education, a shortage of qualified health teachers, especially at the elementary level.
We talked about that, yeah.
Insufficient instructional time dedicated to health, a lack of updated curriculum materials and resources, insufficient focus on elementary health education as foundational, a lack of confidence in health education as a legitimate academic subject.
Perceived as less important.
Sometimes, yeah. Also, scheduling challenges that don't consider student abilities, the impact of back-to-basics school reform movements that might deprioritize health, teachers not implementing programs as intended, program infidelity.
Program infidelity, that's an interesting term.
It means not sticking to the script, basically. Also, unrealistic expectations about what health education can achieve and restrictions on the content and teaching process. It's quite a list. These barriers underscore the systemic challenges in prioritizing and effectively delivering health education.
It really paints a picture of a complex landscape with many potential pitfalls. So, given all these challenges, what kind of recommendations does the article offer for moving forward?
Their overarching recommendation is that violence prevention should be integrated into a larger, comprehensive prevention effort, not treated as an isolated issue. They encourage state and local school boards to adopt comprehensive school health education programs.
Get that CSHP foundation strong.
Exactly. They also call for providing support and technical assistance to school districts in planning, implementing, and evaluating these programs, and assisting in developing age-appropriate violence prevention units that can fit into existing health curricula. Coordinating staff development for teachers and other school personnel is also a key recommendation, ensuring educators have the skills and knowledge to effectively teach these topics.
And what specific elements should these efforts include?
They emphasize strengthening existing school health programs, ensuring that instruction reflects the growth and development of children and youth across all domains: social, emotional, cognitive, physical, and is age-appropriate.
Age-appropriate is crucial.
Absolutely. The content should also be informed by epidemiological data on the health problems of young people, reflect their needs and interests, incorporate the latest knowledge on violence prevention, align with national health objectives like Healthy People 2000 was at the time, and contribute to the overall educational mission of schools. It's about creating a cohesive and well-informed approach that sees violence prevention as integral to a student's holistic development and academic success.
So it's about building a strong foundation in comprehensive health education and then thoughtfully integrating violence prevention within that framework, making sure it's relevant, evidence-based, and well-supported.
Precisely. The authors conclude that while school health education alone can't eliminate youth violence, it provides a really logical and crucial context for delivering violence prevention education. However, it needs to be more than just a one-off video or single lecture.
Not just a quick assembly.
No. It requires a systematic approach with clear goals, objectives, well-designed content, and activities that build knowledge, positively influence attitudes, and develop essential life and social skills, all taught by qualified teachers within a supportive school environment. They also wisely point out that long-term change will also require addressing the broader cultural factors that condone violence. It's a call for a sustained and multifaceted commitment.
Okay, let's summarize some of those key takeaways for you. We've seen that preventing youth violence is a huge societal challenge requiring a multi-pronged approach, and school health instruction can be a valuable part of that. Effective violence prevention in schools isn't just about tacking on a new curriculum. It needs a strong base in comprehensive school health programs.
Right, that CSHP model.
Thoughtfully designed content that considers the developmental stage of students, well-trained educators, and support from the wider community. We've also looked at the various ways this instruction can be delivered: direct teaching, integration, and supplantation, each with its own strengths and weaknesses.
And the theories behind it.
And we've highlighted the crucial theoretical underpinnings, like developmental psychology, learning theory, social skills training, and group influence. Finally, we've touched on the real limitations and barriers that need to be addressed for these programs to truly succeed.
And for you, understanding this landscape highlights that effective violence prevention isn't a simple fix. It demands a systemic effort, careful curriculum design based on sound theory, well-prepared educators, and buy-in from the community. The challenges remind us of the complexity of the issue, but the recommendations offer a clear direction for how schools can contribute meaningfully to creating safer environments for young people.
So considering all this, and especially thinking about how much has changed since 1995 with the rise of the internet and social media, here's a provocative final thought for you. How might the core principles of developmentally appropriate education and social skills training need to be reimagined and adapted today to tackle the unique challenges of youth violence in the digital age?
Yeah, that's a big question.
What new barriers and opportunities might exist for school health instruction now that weren't even on the radar back then? It's definitely something to consider. Thanks for taking this deep dive with us.